So good afternoon, everybody. I think we're now live. It's been very exciting sitting here looking at all of the names joining the event this afternoon. And this is the first key stakeholder event that we're holding to look at the community infrastructure. We've spent quite a lot of time, I think, over recent years looking at what we mean by a primary and community NHS, and we often talk about that in very easy terms, but perhaps don't spend enough time thinking about what the community infrastructure means within that context. And I think it's ever so more important now, and particularly over the last couple of years, where we've really seen the community come into its own. But what do we mean by that? I think many years ago we would have thought about those traditional services such as district nursing, health visiting, the GP practice, social services, but now it means so much more. Our third sector, our independent sector, and a whole range of services that work collaboratively together to form our community services. But in terms of our strategy at an all Wales level, we know that we have got to be able to have a robust and sustainable primary and community set of services to allow our system to work effectively. So we wanted to engage with all of you today to help us to think about that, to think about what that community infrastructure means. And I can see, looking at the delegate list, we've got a really good representation from all parts of our community. But we also mustn't forget our population, because I think, again, particularly over the last couple of years, we've talked a lot more about that social model for health. And thinking about community resilience and the Social Services and Wellbeing Act, which helps us to think about framing some of our response in terms of the assets that are within our community. How do we work with our population to bring about the best set of services that we need going forward? So we've got a busy afternoon, and we're going to be starting off with some videos that we've pre-recorded, and we will encourage you to put messages in the chat bar as we're running those through. We'll be then going into about 5 breakout sessions. You'll be seamlessly put into those breakout sessions at around 3 o'clock. And again, we'll be using Mentimeter throughout that process to record some of your feedback, your questions and your queries. And we'll have the opportunity when we come back just around 3:30 to pick up some of the reflections that are coming through the discussion. We'll get some feedback from the group leaders, and then we'll be finishing off with Alan talking to us about the next steps and how we engage with some of you in perhaps some smaller work streams, but also look at the possibility of some wider stakeholder events again going forward. So just a bit of housekeeping before we do that. We are going to ask that cameras and audio is muted throughout unless you're speaking, please, just to avoid any technical interference that might come about. We'll have a short break at 3:25, just for 5 minutes before we come back into the main session. So I think, as I say, please use the chat bar and Mentimeter at the right times, but I really hope that you find that it's a constructive afternoon that really helps us to think, with all of your assistance, about how we develop the community infrastructure of our strategic programme. So we'll start the pre-recorded recordings now, and you can see colleagues who are going to remain on camera so that you can relate the videos that you see to members of the team who have helped to put those together. So thank you and welcome again to our workshop this afternoon.
Director and Strategic Programme Lead for Primary and Community Care, and I'm delighted to be starting a series of short presentations to frame today's events. As way of background, the Strategic Programme for Primary Care is an all Wales-led, Health Board-led programme that works in collaboration with Welsh Government. It intentionally doesn't sit with any one organisation, but rather works with a number of organisations in order to deliver the programme of work. So to set the strategic context, the primary care model for Wales was first described in Setting the Direction in 2010. And this was followed up in 2015 by the Primary Care Plan for Wales, which provided a series of actions both for Welsh Government and for health boards and included a very detailed workforce plan. This took us up to the end of March 2018, But in June 2018, we received a Healthier Wales, and within a Healthier Wales, it was clearly set out about the expectation to implement the primary care model for Wales. In response to that, the strategic programme for primary care was developed that set out the actions required for primary care in order to deliver the primary care model for Wales. More recently, this summer, we saw the programme for government and the ministerial priorities for 2022-23 reinforcing the need to roll out the primary care model for Wales, and in particular to see cluster working accelerate. So what is the primary care model for Wales? During the time of the primary care plan for Wales from 2015 to 2018, funding was provided for a pace setter programme that basically funded 24 projects on a once for Wales basis. What we concluded from those projects and the learning from the projects was the fact that there were 5 very clear themes that came through across all of those projects. Firstly, that multi-professional team working at cluster level is the way forward. At practice level, it was just too small, but at cluster level, you start to get the economies of scale and can work at that multi-professional team level. In having a multi-professional team, you also have to ensure that you've got safe and effective systems to direct people to the right person or team at the point of contact, so right person first time. Another key theme that came through was that integrated teams ensure a holistic approach to care, so really thinking about the physical, mental and social well-being of the individual. A fourth theme was that services must work well across in and out of hours to ensure seamless care, so really thinking about that 24/7 offer. And finally, success depends upon an informed public who have access to a range of community services. So with that transformation agenda in mind, what are the key priorities for 21-22 for the strategic programme for primary care? Well, they're all grounded in care closer to home. And these priorities were identified by the Health Board Directors of Primary Care. And we have 4 very clear priorities identified, which will be delivered through coordinated activity across the 6 strategic programme work streams. And these are shown on the right. So we've got prevention and wellbeing, workforce and OD, 24/7 model, communications and engagement, data and digital technology, and transformation and the vision for clusters. And the 4 very key priorities that we have start with mental wellbeing, which was a priority for us before the pandemic, but has absolutely come into focus during the pandemic and as a result of lockdown. And we're really thinking about that tier 0, tier 1 offer at a cluster level, and thinking about actually equipping our frontline staff with what that offer is so they're able to signpost. Community infrastructure is one of our key priorities, and we're obviously here today to talk about that, and we'll come on to that a little later. Urgent primary care. We were really keen to deliver an extended urgent primary care offer, thinking about kind of that piece between general practice and ED, and whether we could do that at cluster level, and offering that from a multi-professional perspective as well. We've got 6 out of the 7 health boards providing urgent primary care centres as part of funding that was identified last year, and we've got further funding for this year as well. The final piece is accelerated cluster development, which we see as the infrastructure required to be laid down in primary and community care in order to allow some of these priorities to progress. And we're going to hear a little bit more about that from Alan Laurie later. So specifically looking at that priority around community infrastructure and the why are we looking at this? Well, if we think about the current situation, firstly, when we look at what we've got currently, we've got a patchwork of services. We've got some real pockets of excellence, some really good practice across Wales. But what we can see when we look across Wales is that services aren't necessarily always joined up. And there's a variation in terms of the offer, the description, the access criteria, even the titles of some of these services, as well as the understanding of the services. And then looking at the national context, obviously from a pandemic perspective, community services really did come into a sharp focus, and really understanding what we need going forward in terms of the resilience and recovery of the overall health system and what's required at a community level. So with this current situation in mind, what are we looking to achieve through the community infrastructure? We do want to focus on consistency, we do want to reduce variation, and we want to build on that good practice that we know is out there. The aim of this work is to set out the fundamental requirements of an integrated 24/7 multi-professional place-based model of care. And when thinking back to those earlier slides about the primary care model for Wales, you can see that absolutely aligns with the key components of the primary care model for Wales. So thinking about multi-professional teams, thinking about 24/7 services, that integrated approach in terms of holistic approach to care, and providing a range of community services. And ultimately, our aim is the provision of person-centred collaborative care. So a final slide from me just really summarises, we've talked about community infrastructure today, which is one of the 4 key priorities. Another key priority is accelerated cluster development, and I'm now going to hand over to Alan Laurie, who's going to talk through that and the links between those 2 priorities in more detail. Thank you very much. Good afternoon.
Good afternoon, everyone. My name is Alan Laurie, and I am the National Programme Advisor as part of the Strategic Programme for Primary Care. I am delighted that so many people have joined us today to work to shape what the Community Infrastructure Programme should look like. Prior to my current role, I have been a Director of Primary Community Mental Health Services for over 20 years, working in various parts of the NHS. So I truly believe that strong and vibrant community services are the solution to many of the great challenges we have at the moment. So, over the course of the next few minutes, I'm going to talk a little bit about accelerated cluster development, shortened to ACD, and community infrastructure, which you'll now see on many of the slides as CI, and see what the links are between them. So I'm going to talk a little bit about what we mean by clusters and cluster working and cluster-led planning and delivery, a little bit about what accelerated cluster development is, and finally how the community infrastructure programme underpins the ambitions that we have within the accelerated cluster development programme. So, clusters. They've been part of the landscape for NHS Wales and NHS Wales for over a decade. And you'll see on the left-hand side of the screen a definition around clusters. A cluster brings together all local services involved in health and care across a geographic area, typically serving a population between 25,000 and 100,000. And you can see on the right-hand side the map of the 60 clusters as they currently exist in Wales, broken down into their health board areas. I'm sure we can get a map to you that shows the collection in the southeast, where you can see there are an awful lot of clusters within a small geographic area. And of course, that compares and contrasts to the clusters that we have, perhaps in Powys, over in Hywel Dda, and to some extent up in Betsy Cadwallader as well, where you've got much more diversely spread populations and therefore diverse clusters. 2 key points on this slide I draw your attention to. The definition of working as a cluster ensures care is better coordinated to promote the well-being of individuals and communities. As I've undertaken presentations around accelerated cluster development over the course of the past 6 or 7 months, everybody agrees that that's what we're trying to work towards. The question is, how far are we down that particular track, and can we achieve that? And I would say to you, for those of you who remember Setting the Direction, a paper that came out 10 years ago, authored by CDV Jones, now the chair of HEIW, it is well worth going back to that document for a read. It sets out exactly where the expectation was in relation to services at locality level, within neighbourhoods, how community resource teams would work, what the linkages would be between health and social care, and so on and so forth. And we have not hit everything that we said we were going to do in Setting the Direction. However, I believe what we're doing around ACD and what we're going to be doing in the community infrastructure project will help us in that regard. So why did we start the ACD journey? Well, as they say, clusters are 10 years old, but they have developed to various levels of maturity and influence. Some have significant influence within their cluster and health board area, others have much less so. So we undertook a cluster survey in December 2020 to have a see about where we thought we were, how far we were down that vision of where clusters were meant to be. And what the survey highlighted was concerns around bureaucratic processes, lack of autonomy for a cluster to get on and deliver, some real challenges with having long-term plans linked to the fact that the financial strategies in some areas were quite non-recurrent as opposed to embedded. Too often it was just a GP club talking about GMS issues, and therefore there was a need to significantly broaden the membership, both the other independent contractors but also the wider MDT team. And therefore what came from that was a need to clarify the future purpose and the future functions of clusters. At about the same time, cluster leads were looking at what they thought very, very specifically, and they were talking about needing autonomy in terms of status, the capacity to do work, funding to do such, and it wasn't about GMS services. This was about services above GMS level, not that you would deliver a practice, and that you would deliver in an integrated way across a cluster. It talks about coherence, the fact that each cluster should have a core set of similarities that needed to learn from each other, and that the cluster was a brand. And they talked about engagement and the need to get quick answers from health boards or from Welsh Government or from the strategic programme. They talked about being patient advocates, but they also wanted to be the place where people sought problem solving, etc. And I think there's a real opportunity we continue to have with that, and therefore standardising some of the arrangements. Clusters have done a lot in terms of stabilising where we were in terms of GMS. They've done a great deal in relation to developing MDTs over the course of the past 10 years. I do believe there's a bigger, brighter future for them, and the community infrastructure project will support us in how we move forward over the course of the next year to 5 years. So in terms of accelerated cluster development, there are 7 ambitions or outcomes that are expected from this particular programme, and you can see them highlighted on the slide we have here. And there are lots of words in here around integration, wider, deliver, effective, etc. The sorts of things you'd expect to see. So absolutely, we would expect an outcome from this to be better, enhanced, integrated planning between clusters, health boards and local authorities. We want a wider range of services delivered across a cluster that meets the population needs and priorities. We need to have a greater number of effective leaders in that primary care space, working across the health and care system. Clearly, equity of service based upon local needs is important. We would expect it to be improved multidisciplinary, multi-professional, multi-agency services being delivered, all of which chime in well with where we want to be around community services. Efficient and long-term sustainable workforce solutions and services, and finally empowered clusters that have that increased autonomy, flexibility and vision to deliver on the aspirations that they have. So I think no one would argue with those being the outcomes, and we hope the way in which we pulled the programme together will give us that. And you'll see that in effect there is great alignment between the primary care model for Wales that Sue talked about, which sets the direction, and then what the community infrastructure project is looking to deliver as we move forward. My apologies up front, this is a slightly busy diagram, but it's a diagrammatic representation of what it might look like at a county level. So the expectation under ACD is that at county level there are planning arrangements put in place that have got a very significant and key important membership. Key to that is having cluster leaders within that membership as equal parties, not co-opted, not observers, but actually key members of the planning arrangements for the county, both looking at health services and local authority services or social care services. You expect the right people to be around the table, so senior social services leadership, senior operational NHS leadership, our third sector partners, our public health colleagues, senior colleagues from allied health professionals and community nursing, CHC, and also a voice in there for mental health and secondary care. And we see this absolutely as a driving force, the right people around the table to drive forward decision making about how things happen at a local level. Those collaborative cluster leads would come from, as have been described, the gang of 4. So there will be within each cluster area a pharmacy, an optometry, a general practice and a dental collaborative, leads for each of those, and then one of those will then come forward for each cluster within a county to sit on that cluster planning group. There will also be collaboratives based around community nursing and therapies, maybe social care, and again, those people will have a seat around that PCPG table, really influencing what happens at a local level. So I hear you say, how does all of this link together? So what is the ACD and community infrastructure link? Well, the primary care model for Wales is explicit in relation to the requirements for needing to show multidisciplinary and integrated teams, having seamless services, and delivering the 3R rights: the right person, the right place, the right time. Very clear. Accelerated Cluster Development is a vehicle to deliver the primary care model for Wales. It is about place-based care. It is about collaboration, and they are uniquely placed. They will be uniquely placed to do that within the health and care system. The work of the community infrastructure project that we're talking about in relation to multi-professional working and how to deliver this in an exemplary manner is going to be crucial, alongside the work which we're talking about in terms of community nursing and care homes. Really key elements. If we get that right, that will assist what happens at that ACD level and will allow us to deliver the primary care model for Wales, that place-based care. The community infrastructure project, as far as I can see, is going to deliver tools, standards, information, good practice that really support and enhance cluster work. If we get those products right over the course of the next 6, 12, 24 months, what we do within those pan-cluster planning groups, what we do within the clusters, is it will be significantly enhanced. And finally, community infrastructure, this programme is a major multi-agency and grounded programme that will provide that invaluable support to the primary care model for Wales and delivery every time of the 3 rights: that right person, the right place, the right time. I hope that describes for you what ACD is about, how that fits within the primary care model for Wales, and then most importantly, how the community infrastructure project that we're talking about today will link into ACD. Thank you very much. I'm sure we'll have more questions as we go through the course of today.
Hello, my name is Kerry Phipps and I am the National Allied Health Professions Lead, or AHP Lead, for Primary and Community Care, allied to the Strategic Programme for Primary Care. I'll be providing the detail of what the Community Infrastructure Programme ambition and objectives are, building on the context and information provided by Sue and Alan, with colleagues then following this section in terms of the detail of how the programme will achieve this ambition and deliver these objectives. This includes our ask of you as proposed members of our key stakeholder group. So, as one of the 4 key strategic priorities of the Strategic Programme for Primary Care, and as a core part of the Strategic Programme for Primary Care's 24/7 workstream, the Community Infrastructure Programme will define the fundamental infrastructure required to deliver a 24/7 integrated, multi-professional community model. It will assist health boards, local authorities and key partners in being able to provide the required infrastructure to do so. Recognising that there has been lots of really positive work in this space, but that it's often stood alone and hasn't had traction, this programme provides the opportunity to build on, coordinate and give profile to this work. The use of the word multi-professional instead of multidisciplinary is a conscious one, as this is reflective of the wider workforce and partners, and the required shift from a medical to social model of care. You don't need to be a registrant to be a professional. With the programme focused on a collaborative cluster working approach by all local services involved in health and care for people across a geographical area. Planning and delivering coordinated support designed around the needs of individuals and communities within that area, with a greater emphasis on keeping people healthy and well. As already detailed, this population approach is central to achieving the primary care model for Wales and a place-based model of care and support, where it is identified that multi-professional teams working at cluster level are the way forward, with safe and effective systems to direct people to the 3 rights, as Alan coined it: right person, right time and right place. With integrated team working vital to ensuring an holistic approach to care, providing seamless 24/7 services with an informed public with access to a range of community resources and support. This slide is designed to illustrate how the Community Infrastructure Programme is a core part of the Strategic Programme for Primary Care's 24/7 workstream, a standalone programme of work concerning the delivery of sustainable 24/7 community services. It also illustrates how all of the strategic programme for primary care work streams are inextricably linked, and that the community infrastructure programme, whilst hosted within the 24/7 work stream, will thread across all of these, and in particular underpins the cluster transformation work stream and accelerated cluster development ambition concerning health, social care and partners collaborating and working closely at a regional and local level to provide seamless place-based care with direct access to a wider range of multi-professional support. This slide also references the programme's alignment with the other main national programmes, as well as the AHP Framework Programme and other enabling partners, in addition to capturing its interface between the delivery unit and National Collaborative Commissioning Unit's work on intermediate care, recognising this is a collaborative programme but emphasising its primary focus is on a multi-professional framework across the continuum of primary and community care services. Notably, we've sectioned the multi-professional framework into 3 pillars, recognising that whilst community nursing and care homes are encompassed within the multi-professional models working group, we've identified specific areas of development required aligned to the multi-professional framework, with outcome, quality measure and evaluation and stakeholder engagement recognised as vital components of this programme and underpinning all programme activity. Finally, you'll see detailed a series of task and finish groups or workshops that will focus on the agreed areas of priority across the 3 pillars that will be informed by today's engagement event with you as key stakeholders. To note now, our focus being on 16-year-olds and over and recognising interfaces between children and adults, particularly around transition. The ambition is that this programme of work will provide a consistent definition of community services across Wales, a demand and capacity tool akin to that produced for step-down services, a suite of agreed outcome measures to monitor progress and success, and ways of operating multi-professional models that will deliver the identified 7 key objectives or outcomes. So a whole system pathway approach providing seamless cross-organisational care, treatment and support for people in their home. That people live well and remain in their own home, whether this is in the community, residential supported living, nursing home or other setting. That when required, support and care is accessible, timely and in the individual's preferred setting by the appropriate professional or service to meet their needs. That the multi-professional workforce has the necessary skills, knowledge and ability to work collaboratively together to meet presenting needs. That duplication of visits and collection of information between professionals is reduced and unnecessary access to secondary care is prevented wherever possible, enabling higher quality care and value through reducing variation, waste and harm. In order to achieve this ambition and deliver these objectives, the Community Infrastructure Programme has 3 component parts. The provision of evidence-based guidance, frameworks and quality statements to support multi-professional working, the development and utilisation of data to support multi-professional working and demonstrate its value and impact, and an interface between the Community Infrastructure Programme, NHS Delivery Unit and National Collaborative Commissioning Unit regarding definitions, indicators, data collection, modelling and assessing demand and capacity for intermediate care. Details regarding how the programme will achieve this ambition and to deliver these objectives, including our ask of you, will be expanded upon by my colleagues in the next series of slides.
Hello, my name is Chiquita Cousins and I'm the National Nursing Lead for Primary and Community Care, working with the Strategic Programme for Primary Care. I'm going to talk about the CI programme and the areas of work that we've identified currently to look at. We know that there's lots of great work happening in Wales and we want to understand what this is, build on it where necessary, and share so everyone has the opportunity to benefit. The green box at the bottom of the screen represents the focus on multi-professional collaborative working which runs throughout this programme. This includes developing a definition of multi-professional working and guidance on how professionals within primary and community care work together, developing a shared vision and language and understanding the core skills required to enable people to remain at home, all of which needs to be supported by technology, data collection, analysis, and the timely sharing of information. This is the underpinning structure of the programme. The blue boxes at the side highlight the importance of ensuring that there's a focus on prevention, including using data to inform practice and understanding the value that telehealth and telecare may bring to that. We recognise that statutory services are not the only ones who support people's health and well-being. Engaging with local communities, independent providers and the voluntary sector is as important to this programme as working with health and social care professionals are. Our ambition being to develop resources that enable choice, well-being and independence through understanding and utilising community resources. There are 3 areas of focus set out within the central boxes. Community nursing and care homes, whilst included within the multi-professional models work, were identified as also requiring specific areas of development aligned to the multi-professional framework due to their integral role in the provision of sustainable 24/7 community services. These boxes outline what we plan to deliver by undertaking this work. So if we start with the community nursing, and by that I mean GPNs, general practice nurses, district nurses and specialist nurses who work within this area because of the interfaces between them. To enable these interfaces, there have been some work on developing a national specification for community nursing, but this needs to be supported by a clear framework which outlines what community nursing is, how nurses across areas of specialty work together for their local population, and how they're involved at a cluster and county or locality level. This will be supported by a nursing workforce assumptions document outlining the various roles and opportunities for nurses, alongside consideration of future roles and ways of working. Finally, there will be a specific focus on the development of a consistent way of measuring the work district nurses do, which sits along the current work on the rollout of e-scheduling. Multi-professional models include areas of focus such as virtual wards. We know there are good examples of virtual wards working in Wales, but there also appears to be some lack of consistency on what a virtual ward is and how that may differ from multi-professional reviews, for example. This work would be about agreeing a definition and identifying and developing models of best practice, for example, considering how frailty and end-of-life care are included within this model. We know practice nurses are experts at working with individuals and long-term condition management, but the current way of doing this means that individuals who have multiple conditions may be seeing a practice nurse several times for their reviews. We want to look at what opportunities there may be to build on learning from holistic cancer reviews, for example, so that practice nurses can see people and undertake reviews of their condition as a whole. We want to look at developing and defining a way that the everyday work of professionals and their contribution in enabling people to stay at home can be measured and valued, both as a professional in their own right, so thinking what does that look like for an OT or a physio or a nurse, but also working together as a multi-professional team. This work is supported by developing guidance and sharing best practice around different types of team models that enable multi-professional working and developing what professional leadership collaboratives look like, their roles and responsibilities to ensure that AHPs and nurses have a strong voice both at the cluster and county or locality level. The last area is about care homes, and by this I mean care homes both with nursing and without nursing. This is about how do multi-professional teams provide wraparound support for what are some of our most vulnerable population, And how can we work with care homes and their staff to understand what they need from us to support and enable their residents to live well? This will help us to understand and value the skills that registered nurses and care home staff have that enable them to support their residents, and to identify where there are opportunities to work with care home colleagues on areas of development that would benefit both residents and care home staff. For example, is there an opportunity to develop policy and guidance where care homes are supported to administer immunisations to their residents, and what would this look like? So our thinking is that by focusing on these areas, they will help us achieve the vision of a collaborative whole system approach to supporting people to stay at home and enable professionals to work at the top of their licence, delivering prudent healthcare. But we also need to make sure that this is underpinned by a clear evaluation and outcome framework. By undertaking this work, we hope that this will support the accelerated cluster development work that Alan discussed earlier, but we also see that these are pieces of work that will provide benefits in their own right. To support the development of any principles, guidance or quality statements, we plan to follow the principles outlined in this slide, where we consider what are we trying to achieve and why, who can tell us what's needed, and how will we know we've made a difference? This will be supported by a process of considering current research, for example via literature reviews where required and where this adds value, considering good practice in Wales and elsewhere, thinking about what are the ambitions or possibilities, and developing models, guidance and principles based on this, underpinned by an evaluation framework. These can then be tested within health boards, so professionals using these products can ensure they make sense, are user-friendly, they add value and help support or improve practice. By following this methodology, we hope the work produced will be useful and relevant to professionals, clusters and health boards. Thank you.
My name is Karen Gully and I am a National Professional Advisor working with the Strategic Programme. My background has been in general practice, but also working in and around primary care, and particularly in the area of cluster development over the years. And I wanted to take this opportunity just to talk in a little detail about why the Community Infrastructure Programme has such important objectives for the work that we're trying to achieve overall. I thought it might be helpful just to talk in relation to, an individual experience. I met several years ago with a family where the elderly parent had recently been discharged from hospital and was back in his own home where we would want him to be. And his care had been very carefully planned. But the outcome of that was that he had 18 separate visits every single day as part of his rehabilitation programme. Each of those incredibly valuable, carefully thought through, but in totality that left him exhausted and also quite frustrated at having to explain his experience and his needs so many times. And his family were just baffled by the lack of coordination and communication, and very concerned for the impact that would have on him. And obviously that's a scenario that none of us wants to see, and a huge amount of work has been done to coordinate care and improve communication. But the infrastructure programme is really about helping to take forward the improvements that our frontline services recognise need to happen, and those are structured in ways that we hope will enable us to move faster and more efficiently and effectively at making things better for patients, but also easier for people to do their job, which is what we all come to work to do. So we talk about the pathways and the seamless cross-organisational care that we all want to achieve. And I think that example shows how much dialogue around the planning of services can make such a difference when we try to put that into practice. We want to support people wherever they are, so their home will be where they are living, which may be a nursing or residential home, equally, or in their own family setting. We want to make sure that care is timely and accessible, and that's another reason why we want to be as efficient as possible and not duplicating care, because everyone on the front line, particularly through the COVID pandemic, has been extremely busy, and anything that we can do to make those roles more manageable has got to be a real priority for us all. There are lots of new skills and roles in the workforce, and the programme is really interested in making sure that we all understand each other's skills and abilities, and that we make the best use of those around every individual, just like the gentleman in the example that I described, who really needed us to build the care around him and his needs, and in supporting his family, because they were also a crucial part of keeping him safe and well at home. And outcome 5 of the programme is around minimising the duplication of visits, the duplication of collection of information, and really making professionals' lives much better, having the information they need in front of them at the time that they need it, so that they can do the job that they really, really want to do. All of this clearly is around minimising the unnecessary use of secondary care. And I think that particularly leads us on to the real ambition of the infrastructure programme to provide the skills and capacity 24/7. So not just in the normal working day, but when patients and families need that support. And lots of examples are emerging of how we can do that really effectively, so that care is really seamless over the 24-hour period. I mentioned lots and lots of really innovative examples of care, and we want to be learning from those and using that knowledge to reduce variation, waste and harm as part of a core way that we approach the way we get the work done. All of this requires that frontline knowledge and experience, feedback from patients, carers and families to inform us about what needs to happen. And then the programme is really trying to put the infrastructure around that so that those great ideas can be taken forward. None of this will happen without the engagement of people who know what it's really like on the ground. And so the stakeholder group and the task and finish groups are all seeking to get as much engagement from yourselves and your colleagues around making this programme really effective. So there are areas such as the community nursing focus, the multi-professional model, including virtual wards, and then the work on care homes, which obviously has been enormously developed over the COVID period, and we really don't want to lose some of the really great work that has been delivered. This afternoon, we really hope that this will give an opportunity for everyone on the event to think about where they want their input to be focused, and there are opportunities across, as I mentioned, the stakeholder groups, the task and finish groups, individual workshops, and we would really encourage you to think where you would feel you can most contribute and get most satisfaction from seeing the change that you want delivered. It may be yourself, or you may wish to nominate peers who have really important skills that we could use. So as part of this afternoon, we hope you'll keep that in mind as we move into discussions around how we take this really important programme forward.
Thank you very much to our contributors there, and I hope that it's given all of you a sense really of what we're trying to achieve this afternoon. We've heard a bit about the what, the why and the how, and it's now our opportunity to think about how we shape and influence that. And whilst those videos have been progressing, we've seen quite a lot of chat coming into the sidebar, and I think just the opportunity perhaps for 10 minutes to reflect on some of the themes that are coming through that you may want to explore then further within your work groups or your breakout groups, and perhaps to ask some questions to clarify any particular points. So I just wanted to pick up a few themes. So I know coming forward quite strongly were some questions around membership of the clusters, but also more generally how people are going to engage in terms of AHPs were called out, nursing was called out, and also some of our independent contractor professions who are mandated actually through their contract to work within a cluster. So Alan, I know you've answered in the chat bar, but do you want to just clarify that for a moment?
Thanks, Jill. Yeah, it's as we've been developing the accelerated cluster development programme, we were very keen to ensure that there was very senior representation around what we've described as these pan-cluster planning groups who will be responsible for thinking about the planning and delivery of services. So not just a cluster lead, not just senior people from social work or from the local operational delivery in the NHS, but actually ensuring senior AHPs, senior community nurses had a seat around that table as an equal partner. Now that does happen in some places. There are parts of Wales where there are county level arrangements that have been established, and they do have those individuals sitting around the table. But we're very keen to ensure that takes place. I'm absolutely, I fully accept terminology is really important. So the point that Ruth Crowder has made in relation to the terminology AHP is very, very important. And it may well be, as time goes on, that in a cluster footprint, a cluster area, that our senior community nurses, our senior AHPs will want to form their own collaborative, and that's fine. That'll be part of the deal and part of the ability to do that. Equally, where they do currently engage with clusters, we would want them to continue to do so in a very inclusive way, and we'll be working out how that can happen. So nobody is excluded from this at all. It's about trying to make sure we've got the inclusivity, which does exist in some places right now, but not everywhere. So trying to get it everywhere, making sure we've got strong voices around the table. I know Chiquita and I met with senior community nurses a couple of months ago, and had really never had the opportunity to get around the table with colleagues in that kind of way. But in some places they did. So let's get everyone able to do that, and to really be able to further this across the whole of Wales in that way. We are going to be through the contract reform process, making sure that we have got proper representation from dental, optometry and pharmacy. Pharmacy have currently been leading the way around that bit and have got identified leads, but we don't really have that in optometry and dental. Again, we're working to make sure we've got those people as independent contractors sitting around the table. So I think, Jill, absolutely, inclusiveness is the key around this, because it's all about population health and how we respond to the population health agenda. Hopefully that provides a bit of reassurance about where we're going in that space.
Thanks, Alan. Another important part that came through from some of the chat in the themes was about the independent sector. Chiquita's brought out the engagement around care homes specifically, but some questions have been asked about domiciliary care, another area and part of our system that's under considerable challenge at the moment. So Chiquita, could you just respond in terms of how we're going to perhaps include a focus in that piece of work around domiciliary care as well?
Thank you. So I think what we have identified from talking to people is that maybe that's an area we haven't kind of totally considered, which is why it's really good to have this event today to understand what are the gaps and how we can then engage in moving that forward. So I know we've had some conversations with members of the group today, and we are really keen to explore how we could be working to support and integrate and involve domiciliary care and other independent providers within this work. So looking forward to considering how we can do that. Absolutely.
Thanks, Chiquita. Sue, I just wonder if you could pick up the question around engagement with our local authorities and regional partnership boards, because it's really important that we set this in the context of that strategic approach. And I know that from a regional partnership board perspective, clusters are picked out particularly in the population needs assessment that is underway. So I think there's a growing link there. I wonder if you can elaborate on that.
Yes, happy to, and completely agree. It's very, very good questions. We had a couple of them coming through in the chat bar, but absolutely, what we want to make sure that everyone understands is this is our lens on place-based care. So it's the primary care kind of action plan for place-based care, and we have been working with the directors of social services. We've been working with RPB, so we're doing a bit of a roadshow with them. And really trying to understand, okay, this is what we're doing, where does it fit in terms of the future? So really understanding what the local arrangements are and where some of this wider model can fit into that. So those discussions, as I said, we're underway with discussions with the RPBs. So I think we've done 2, and so we're on our way around them. But we have regular meetings with directors of social services, and then more generally in terms of the discussions in Welsh Government with policy leads to really understand, actually going forward, how do we get that population needs assessment in such a way that all players can actually work with that population needs assessment together. And at the moment, some of our planning timelines and some of the way in which we work can sometimes be a little bit out of sync. So how do we make sure that is as aligned as possible to support this work and provide a real framework for this work going forward?
Thanks, Sue. And one of the other areas that I think has come forward strongly is that challenge around workforce and the need to actually look at a stable workforce at a time when, as I say, we're under considerable challenge in terms of being able to deliver the care that we need. Kerry, I wondered if you could just comment on the importance of the workforce and also the education and training component. I know colleagues from HIW have highlighted that as part of the programme. So Kerry or also Karen might want to come in on that point as well. Thank you.
Shall I come in first? So definitely. So for those who aren't aware, there's from a HIW perspective, there's a developing programme of work for primary care education framework, and this is going to be really helpful, really important in terms of how we optimise the utilisation of our workforce, how we identify those areas of development and skills requirement going forward, so that in terms of working collaboratively together as a multi-professional workforce, where are those areas of gaps, where are those areas of development that we can undertake together to build that team working to support our population in terms of going forward. The urgent primary care model has been a really helpful example in terms of that, in terms of presenting needs and how we can develop our existing as well as identify gaps in terms of future requirements, primary care and community care workforce in terms of meeting that. Karen, I don't know if you want to come in and add anything further.
Yeah, I guess, I mean, I think critical for me is recruitment and retention has got to be about obviously your workforce experience as well, because we all know that we're all seeking to recruit in short term and the challenges that gives. But actually, this is about the medium to long term, is to creating an environment where people feel part of a network where they know their peers, they're working in a stable environment, a really productive environment that they feel they can contribute to. And so part of our work is around the OD programme, which is really, really about the original concept of clusters is you could work around a population where you knew the people you were working with to meet those needs. So you're getting down to a local enough level to be able to make those personal relationships. And I know a lot of the chat has been around who's round the table, and I suppose for me a little bit, but the table's a bit of a virtual table, is actually it's who can you work with to get things done. And so that brings people together because these are really effective networks that progress things and actually make it easier for people, as I said in my comments, to do their job, which is going to be critical to recruit and retain staff, you know, from all backgrounds.
Thanks, Karen. And if I can just stay with you for the final point that I'll bring out, and that's the importance of the patient in the system. And you talked very much about that importance of an integrated model of care. And I wondered if you could elaborate on that. A couple of colleagues have highlighted the people that get stuck in our system when we think we're joined up, but clearly that doesn't always happen. So perhaps you can comment on that.
Yeah, and I think it's really important, this isn't new, and I know a lot of colleagues on the ground are really trying to make these changes work, but we know that personalised care has a huge impact on the quality and safety of care. This isn't just an add-on, this is a core part of what we do, and that's why so much of the focus is on getting local enough and allowing teams to build local systems that work around the individual. And we know where we've given people time to set up their MDTs, to meet with their colleagues, to make smart decisions around how we can effectively support patients, things work well. But people are incredibly busy, they're working in very complex systems, we're putting barriers in their way. So a lot of this work is around trying to create those kind of micro team environments where people can actually get the job done, and then they've got a really, really simple route to take the challenges into the planning groups and the infrastructure around them to solve those problems. And it's really making sure that people doing that clinical work aren't getting bogged down in things that other people can solve for them. I think that's a critical part of it as well.
Thank you. So thanks to all of the team for picking up some of those themes, and hopefully now as we move into breakout groups there'll be further opportunity to explore some of the issues that have been raised this afternoon. We're going to be asking you to think about whether or not there are key areas that we haven't properly explored or considered, such as domiciliary care, that we need to include within the programme. We also want you to think in your groups about the sort of areas of priority that we should be addressing. There are many priorities, as we know, but what would be some of your key thoughts around that? How would you also like to be engaged further within this work as we take it forward? So we're going to go into 5 groups. There will be a group leader. We'll have 25 minutes followed by a short comfort break, and we'll be coming back into the main room then for some feedback from each of the group leads. So just thank you for your contribution in anticipation of that going forward. So you will be moved seamlessly into your breakout group, and we hope you'll have a constructive session, and we'll see you back here at 3:30. Thank you.